All right. Let me share my screen. All right. So again, this topics for this week are uh, tissue integrity and elimination. Wow. All right. So tissue integrity. All right. The skin is the largest organ of the body, right? It is our biggest protective barrier that we have. So one of our goals, right, is to help people to maintain their, healthy skin and tissue, maintain that skin integrity. Any disruptions in skin integrity affect multiple systems, as well as functioning of the body. And so lots of different things can occur. I mean, think about it, uh, impaired skin integrity can be anything from a simple, um, what do you call it, a paper cut, right? To full thickness damage. And when we look at pressure areas, um, they can again be very partial thickness loss, or they could go and, damage the dermis as well as muscle tissue, bones, nerves, and the underlying tissues. And as we get older, unfortunately, some of the changes that do occur make our skin and mucous membranes more vulnerable to damage. So, what do you think happens? Anybody know what happens to the skin as we get older?
It loses elasticity.
Okay, it absolutely does. It loses elasticity. What else happens?
It becomes more fragile.
More fragile, right? The skin thins. Um, there's a decrease in moisture as well as we get older. And things like lean muscle mass, subcutaneous fat often is decreased as well, and that leads to like wrinkling, or that even more loose skin. Um, so lots of changes, and the elderly need to be protected. Their skin needs to be protected. Other things too, when we look at the elderly population, some also have diminished pain perception. So, think about it, right? You're sitting here and you're sitting in class or you're sitting in a lecture. Um, how many times do you move, right? When you're just sitting, you start to get uncomfortable, right? You reposition yourself, you move. With the elderly, if they don't realize that there's any excessive pressure, right? They may develop pressure areas without even realizing it. Um, we also look at the elderly population too with decreased blood flow, whether they have things like peripheral artery disease or peripheral vascular disease. Blood flow to the skin is super important, right? Especially if a wound does occur, right? So we need to have accurate or adequate blood flow. Um, Growth of hair, nails also slows with aging. There's decrease in sebaceous glands, so that's why their skin can often be very dry, very itchy skin. Um, so this is your normal skin, or not normal skin, but this is a cutout of what it looks like. Your epidermis is that upper layer, right? Your dermis is that nice thick middle layer. And then, of course, your fatty tissue, your adipose tissue is down here. Blood vessels are in your dermis. Your glands are in your dermis. So your sweat glands and your sebaceous glands, your melanocytes, are people are still coming in. So just to give you an idea, so that initial damage to the skin, especially for like a just a reddened area. So think like if you were, sitting and you had your legs crossed, what happens when you uncross your legs? You see those little red spots, right, on your like by your knees or maybe on the side of your calf, right? Generally speaking, those little red areas will go away. Um, but that could also be a stage one pressure area or even, progress to something a little bit larger for, someone who isn't, repositioning themselves. So again, here's some of those changes that we were talking about. So decreased subcutaneous fat can lead to that wrinkled skin. Um, you know, in addition to when we look at decreased muscle mass and decreased subcutaneous tissue and other changes that occur within the endocrine system, right? Ever notice that older people are always cold? Doesn't matter how hot it is, they're always cold. Um, with the decreased peripheral circulation, their nails get thicker. They may turn yellow. Has anybody ever seen those really thick toenails on some of our older population? With the decreased thickness of the epidermis, makes it more susceptible to damage. Increased capillary fragility leads to more of the bruising. And then again, the decreased sebaceous fat and sweat glands leads to the skin, dry skin or overheating. Um, Even just something like a simple bump can cause a skin tear in a susceptible older person. And I've seen some pretty significant skin tears just from minor bumps that you wouldn't normally think would cause such damage. All right. So what happens when our tissue integrity is interrupted? And so perfusion of blood and oxygen are affected. Again, the thermal regulation is affected. Their risk for infection increases. Their fluid and electrolyte imbalance is affected. Movement is impaired, right? Especially if it's over a joint. Think of scar tissue over a joint, right? Maybe more difficult to use that joint, and body image may be disturbed. So, that these are pretty significant issues that can occur. Who's checked skin turgor before? Where do we check skin turgor?
The
The
chest.
forearm or the arm or the hand.
Chest and top of the hand.
Very good. The chest, the top of the hand are some really good places to check skin turgor. And what do we check skin turgor? Why are we checking skin turgor?
For hydration.
Dehydration.
For hydration. All right. So you want to compare, right, one side to the next. Because if they have, maybe some loose skin on one hand and not some loose skin on the other hand, right, you may get two different results. Same thing. You can use the forehead as well, the sternum, collarbone. So those are some things that we can use to I'm getting older, so my skin's a little bit, kind of already tenting a little bit. I am hydrated, at least I think I am. Um we touch the skin, that helps us to determine temperature, right? What's the most sensitive part of your hand?
The fingertips.
The fingertips and the back of your hand. That's why when you were little and you say, Mom, I don't feel good, she would go back with, right? And touch
Mm.
your forehead with the back of her hand because it's more sensitive. We're looking for color changes and dryness of the skin. How do we assess color changes in a darker skinned individual?
Wouldn't you look for like just darker areas and even like grayed areas?
Right. You can look at the normal skin color and then look for areas that are darker than the surrounding area. Very good.
So see if they have like purple spots more so it's like a dark purple spot.
Right. Dark purple spots or even just darker, like darker skin colored areas. It can be a little bit more difficult making, especially if you're in there at night and trying to do a skin assessment. And pressure areas obviously aren't the only things that we worry about with the older adults. There's things like rashes and irritation that can occur even in the older adult. We won't find like chicken pox in the older adult, right? But we will find some other types of skin issues. So rashes can be from irritants. It could be laundry detergent. It could be soaps. It could even be lotions. Your communicable diseases. What are some of the communicable diseases that we may find in the older adults that would cause a rash?
Shingles,
Shingles,
contact dermatitis,
contact dermatitis,
um, eczema,
eczema.
So would it be psoriasis?
Say that again. Shaquana, say that again.
I think she said psoriasis.
Oh,
I think
psoriasis.
so.
Okay.
Sorry.
Those aren't communicable. Would be another communicable one.
Scabies.
Scabies. I didn't want to say it, but yes, scabies is another one that you may possibly see. Um, Allergic reactions, of course, allergic reactions are always possible. Autoimmune disorders, medications can cause rashes as well. And so all of those examples you've already said, your contact dermatitis, your pruritus, impetigo, eczema, psoriasis, these are all different types of rashes that you may see in an elderly client. So xerosis is dry skin. Um, and so um it's 75 or what is it? Yeah, 75% of older adults have dry, flaky skin. Um, it's just something that I don't know. Sometimes I think it just happens. Um, it can be caused by the reduced production of oils in this from the sebation glands. Dehydration is a big one, as well as nutritional deficiencies. If they have any chronic diseases like what do you call it? Diabetes or kidney disease, and then of course harsh soaps or detergents, right? So think about um, using when we use bleach and things in the sheets, right? It can be irritating to the skin. It can result in itching. And what happens when we itch? We scratch. And then what happens when we scratch?
You break the skin.
We can break the skin, right? And then that will allow for bacteria and other things to get into the skin. Um, So, think about it. I'm not going to ask the question, but, a lot of people take a shower every day, right? Maybe even wash their hair every day in that older person because of the decrease in the sweat glands and the decrease in the oil production, right? They don't really need to shower every day. The normal washing your face, right? Brushing your teeth, that kind of thing. But their skin doesn't need to be scrubbed every day. It's just going to irritate the skin even more. So we use more mild soaps. With the elderly population, and they should be using lotion. Lotion will help to keep the skin, nice and moist and a little bit more, what's the word I'm looking for? Less dry, right? A little bit more moist. Different pigmentations. So these are also pretty common with aging. Many are cosmetic. They usually don't cause any problems. They can be on the face or the arms. Most of the time it's just, it could be bothersome to the person. But like your senile lentigo, which are your age spots, um, as we get older, we have fewer melanocytes. However, they are fewer but larger, so it leads to the formation of those age spots or liver spots, as they are sometimes called. The acne rosacea, which is in the picture above, um, it's triggered by sun, heat, hot drinks, spicy foods. And it's usually right there on like the redness. It will be like right on the cheeks. So they look, like they've been outside in the cold and their cheeks are all nice and red, or they've been out in the sun. They look like there's been a little bit of sunburns. Um, but changes in when we look at moles, just like we look at moles when we're doing a skin assessment on any adult, right? We still want to look at moles and things in the older adults. Um, because that can still, of course, lead, they can still get cancer. So, we keep an eye on the moles, any changing skin lesions, any irregular lesion that bleeds or does not heal, that's darker than normal, that changes color or shape should be evaluated. Um, our mouth. We all know how important our mouth is for eating and chewing, even talking, right? Having a conversation. So some of the changes that occur with the older adult as they get older, xerostomia is dry mouth. Um, it can be caused by dehydration, by medications, by cancer treatments. So think about like your chemo and radiation. It also can be the result of certain disease states, diabetes being one of them, not the only one, but diabetes is the one that can lead to dry mouth. Um, think about if your mouth is dry. Anybody ever seen a tube feeder's mouth? What does a tube feeder's mouth look like?
Um,
Real donkey.
Don't they
Really
have
dark.
like
they
white thrash on it?
if it's not cleaned properly, they have a lot of like plaque buildup.
Hmm. So they get plaque buildup. They also get like the mucus that is in their mouth. It dries and it adheres to like their teeth, their mouth, their tongue. So you remember they're not taking I should say most patients that are tube feedings, right? They're not tube feeders are not taking anything by mouth. So their mouth is going to be excessively dry. So it's really important that we do good oral care on our tube feeding patients. Um, but if
Miss
your mouth,
Martinez, but
yeah, go ahead.
that's not considered as the leukoplakia, right?
No, that's different. Yeah.
Okay.
So I was looking at this. This is the leukoplakia, which is the white patches underneath, which is a
Mhm.
sign of oral cancer. It is something that we do need to look at. Um, this one up here, I don't know what that is. I thought maybe at first I looked at it thrush, but I'm thinking it might be just leukoplakia as well. I was trying to see if there was like another picture I could look at to kind of compare, but I can't find one. So, um, but with the dry mouth, even if it's not a two feeder, even if it's somebody that, has dry mouth as related to one of their, disease conditions or something, oral care is super important. Um, who's ever bit their tongue before? Okay. And then after you bit your tongue, how has that affected your eating? I know it sounds kind of silly, but
You
how does
don't
that
want to eat. It's painful.
it's painful, right? Or even if you get like, I don't know, like a crack in the corner of your mouth from like really dry, right? Things like lemons aspire. Well, I always go right for lemons, right? Because that's gonna burn like heck, right? If you bite in on a lemon. Um, anything spicy. um, or harsh or even like hard and crunchy, right, could cause irritations to that. um and we already know that the older adult, we have issues with them eating as it is, right? We don't want to try to increase that. So we want to make sure that we're looking at their mouth and taking care of their mouth. um you can do saltwater washes, notify the provider. There is artificial saliva. Yeah, I saw that look, Jackie. Yeah, I was wondering where they got artificial saliva myself. But no, it's commercially made. It's it's commercially made. Um, and it kind of coats the mouth and helps to keep the mouth wet. Trying to think there. Biotin is one. It's really good as well. I don't know if anybody has heard of biotin. It's like a mouthwash. That's a really good mouthwash for the older adults as well. Helps to keep the mouth moist. But even like, you know, say that that older person has all of their own teeth. Dry mouth also increases the risk for bacterial invasion, right? And we can then start to have issue with our teeth. So we do want to do, I'm gonna tell a story. So this was a long time ago. This is probably when I first started in nursing. And we had a tube feeder. And I don't know what happened. For the most part, everybody was really, really good about doing oral care. Um, and so, well, long story short, this one poor lady, um, I don't remember who said something. I think I had just walked in the door. I don't even think I had done rounds yet. And I think one of the either like the one of the assistant directors or the DON or somebody was like, "Hey, can you please make sure so and so gets oral care done?" And I'm like, "Sure." So I let the CNA know, and she was like, "Okay." She goes, "I'll get it done." She was like when she did her that resident last, because the resident was a two-peter and there was other stuff going on, so she didn't get out of bed, so she was getting all the ones that were eating breakfast and stuff, getting them ready first. And I said that's fine. So I gave it a couple hours and I went in there and I could hear gurgling, and so I was like, what is going on? And she had not done the oral care that I had asked her to do. So I went ahead and did it because I couldn't figure out what this gurgling noise was. Y'all can see me, right? I pulled out like dried mucus that was probably about this thick and about that long. That was just sitting like in the back of her throat, and it all came out in one piece. It was absolutely disgusting. Um, And so to me, I probably I took some responsibility for this too. Um, that wasn't one day of no oral care. Okay. That had to be a couple of days of no oral care. And so I got written up, of course, and, as did, a couple of the CNAs as well. So, it's got to be really uncomfortable, right? I hate when my teeth feel dirty. I don't know about anybody else, but when my teeth feel dirty, like my mouth feels dirty. And I'm uncomfortable with that. Never made that mistake again. Always check everybody's mouth. And leukoplakia, like we were talking about, I think it was Naomi pointed out, this is those little white patches on the gums or even in the oral membranes. Common causes are tobacco use. Alcohol can be a contributing factor as well. Leukopenia generally does have a poor prognosis. All right. So let's do this. So we're going to match the impaired tissue integrity. So we have choices. We have candidiasis, we have a skin tear, we have melanoma, and we have scabies. Ooh, all right. So which one do we think this is?
Skin tear.
That's a skin tear. Which one do we think this is?
Scabies.
And then what do we think this one is?
Fungal.
And last but not least,
Melanoma.
melanoma. Has anybody ever seen scabies in real life?
Mm-hmm.
Yes.
All right, so there you go. So yes, your skin tear. When I first looked at this picture, I was like, oh, it's a pressure area, but it's not. You can see it's just the blood underneath. Yes, this is your yeast infection. This is your scabies, and this is your melanoma. Um, so feet. Let's go back to those really thick toenails that you may see on some of your older adults. Um, a lot of older adults don't pay attention to their feet. 100% don't pay attention to their feet because, for one, they may not be able to see them. Two, they may not be able to reach them, right? Not all older adults have great flexibility. Although I've seen some older adults that, I mean, are extremely flexible. Um, they should see a podiatry that will they'll to clip their nails and inspect. We don't clip toenails anymore. When I first started in nursing, we did toenails. We clipped toenails, we did fingernails, we did everything. Um, and now we do not. Why don't we clip toenails anymore?
Insurance purposes. Nah, because of
Diabetic patients.
Go ahead, Naomi.
no, I just said it, but I was making a joke. I said because of
Of insurance, yeah. What about diabetes?
yes. If you cut their toe, it's hard for them to heal.
Right. So if you accidentally nick some skin, um, even not even realizing that you nicked the skin because some of them may not bleed, right? That can lead to an infection.
You also have to worry about people that are on blood thinners when it
But
comes to
then,
accidentally cutting their skin.
yep, absolutely. Good point. Um, those thick toenails, okay? If you have not seen them, okay, you can Google hyperkeratosis, or onychomycosis. Those are some of the causes of some of those thick toenails. There is no way that you can get nail clippers around those toenails to clip them. So they need to have a podiatrist see them. And the podiatrists actually use Dremels. Everybody knows what a Dremel is. It's a tool. It's got lots of things and it has a little sanding option, a little grind. It's kind of like if you go to the nail salon and get your nails done, that little tool to like shape your nails and stuff. It's the same concept. They literally will grind those thick toenails down. So they have grinding option, and of course they have a sanding option as well. But that is how they get that is how they cut down some of those really, really thick toenails. They also have decreased sensation. So, kind of like what Maisha and Naomi were saying, right? You get up in the middle of the night to use the restroom and you bump your toe on on your bed frame or your door jamb, right? Most of us probably wouldn't even remember that we did it in the next morning, unless, of course, we break a toe or something like that. But an older adult may not even realize that, if they have that decreased sensation as a result of peripheral vascular disease or diabetes or some other, issue, they may not even realize that they have a cut on their toe, which again can lead to infection. Um, and if we're in worst case scenario, right, it could lead to amputation, whether of the toe or part of the foot.
Miss Martinez.
Yes.
It's a little off, but my grandfather, he had diabetes and he lived in Belize, and he started to have neuropathy in his feet,
Uh-huh.
and they suspected that it was a rat that bit the back of his foot, like the heel, and that he had it for so long he didn't even know he almost had to literally get his foot amputated.
Oh my gosh.
Only reason he didn't get it amputated was because he ended up on dialysis and ended up passing away. So
Oh, I'm sorry.
I'll
But
get that.
yeah, I mean, then we don't think about things like that too, animal bites or um I mean, this is off topic as well, I think, but I had a patient who was 36 who got bit by a brown recluse spider and ended up having she ended up getting osteomyelitis from the spider bite, started with a below the knee amputation, and the wound still wouldn't heal. The surgical wound from the amputation wouldn't heal. It tried a wound vac, and then she ended up with an above the knee amputation just from a spider bite. Um, so yeah, this is why, making sure that we're there, that person is inspecting their feet every day, because those minor things can cause some significant issues, especially if there's compromised circulation.
One of my patients too, he was diabetic and he ended up his toes going necrotic, and he had on his socks one day. He was taking his sock off and
And they fell off.
his toe fell off in the sock. So they
I've heard that happen.
slowly started to cut toe after toe after toe, and eventually he's a below the knee amputee now.
Yeah, I've heard of that happening. I don't know how I would react to that, be honest. Not sure how I would
And
react to that.
he brought the toe to the office, a family
Mm.
practice office.
What did he think that y'all were gonna do?
Probably glue it back. Who knows?
Oh my gosh. Oh, I yeah, I've seen a lot of funky toes in my career. Foot care is so important. That is, I will tell you, that is one thing that my mom always used to tell me. Foot care is really important. Take care of your feet. If your feet are happy, the rest of you is happy. Um, but think about it. Just anybody ever get a cut on their bottom of their foot and had to walk on it? Okay. So it's, all of your weight goes on that area.
I had
Um,
an abscess on the heel of my foot once because it bounced off of the head of a nail of like a flooring strip. And it didn't even break skin, but somehow I ended up with an abscess.
mm, mm,
I know
mm.
growing up in Belize, like because we walk on the sand so much and the floor is so hot, like underneath your toe, like the crack underneath your toe, it used to always separate. And when that separates,
Oh yeah, that's horrible.
that's it.
Yeah, I agree 100%. I've had that happen. So yeah, so inspect their feet, teach the elderly person to inspect their feet as well. Hair loss is also a common problem. Alopecia usually indicates a systemic problem. Not always, but a lot of times it does. Um, Diminished hair on the extremities can indicate reduced circulation. Um, so like everybody has hair on their big toe or their toes, whether they want to admit it or not, whether you shave it off or you leave it there. Your toes, the top of your foot, right, around your ankles, everybody has hair in those areas. So diminished hair, especially in those areas, could indicate that there is a impaired circulation to that area just because, right, your hair follicles need blood in order, and the nutrients in order to grow. So we look at that. Genetics, of course, hormonal changes, that's going to affect hair loss as well. Doesn't always, necessarily mean that there is a systemic problem, but diminished hair, especially on those lower extremities, could indicate that they have reduced circulation. So now we'll get into these wonderful pressure areas. I love pressure. I love wounds. I don't love the fact that people get wounds. I hate that part of it. But I love wounds and all of this stuff and working with them and doing all the things. Um, So when we look at wounds and we look at the risk factors for pressure areas, we talked about some of them already, right? So compromised circulation. If I don't have good blood flow, whether it's peripheral vascular disease, peripheral artery disease, that's going to increase my risk for developing a pressure area. Restricted mobility. All right. If I'm bedbound for whatever reason, or even sitting up in a wheelchair. If I'm unable to reposition myself in the wheelchair, then that's going to increase my risk for pressure areas as well. Just because a person gets out of bed doesn't mean that they can't develop a pressure area. All right. So sitting in the wheelchair and not moving for hours upon hours can cause pressure areas as well. Altered level of consciousness, right? If I'm not alert or awake, just laying, may also lead to pressure areas, fecal or urinary incontinence. This is another pet peeve of mine. Nobody should ever stay wet or dirty, but the stool, the urine sitting against the skin, right, can cause additional skin breakdown. Nutritional problems. Oh, all the nutritional problems, right? Um, And then sharing and friction is another big one. This is why when we teach you to reposition rather than sliding them up in bed, we want you to lift, right? So that we're not rubbing their skin along across the bed. But the elderly population, and we look at nutritional problems, we know that there's some issues with that, right? Making sure that they're getting adequate intake, especially with fluids, nice, well-rounded diet, offering them snacks in between meals, getting a nutritional consult in there to assist as well. Um, the pressure areas can have a huge negative effect um, on the overall health of a client. It can lead to infection, pain, loss of functioning, and even death. Um, we had recently, I've had two in the last month who have um, and I don't know where they got the pressure areas from. So I don't know if they were at home or got them in the hospital. Can't answer those questions. All I know is that I have two that have developed osteomyelitis as a result of pressure areas, and have had to go to get them debrided, and get put on IV antibiotics. And it's pretty significant. Um, especially an older adult. And some of those antibiotics are huge, they're really heavy hitting and can cause some other issues, liver, kidney issues, other things. Um, so with pressure areas, these are some pictures of the areas that you would look at. Um, so pressure areas are categorized or staged based on their appearance and the depth of tissue penetration. So when we do, you get a patient and of course, a formal assessment is going to be done at the time of admission. So we're going to do a risk assessment. Anybody heard of a Braden scale before? So Braden scale is what we use to determine the risk, right, for skin breakdown. Nutritional assessment is also a good one to do as well. So these are some areas, all right, that you especially want to pay attention to. The back of the head, the shoulder, the elbows, the buttocks, the heels, the ears, the shoulders, the hips, the thighs, the legs, that see rib cage here, um, medial and lateral malleolus, the posterior part of the knee, trying to think of where else. Anywhere, just you can feel on yourself, anywhere that you have a nice little bony prominence, okay, that is going to put pressure. I had patients I've seen them on the back of the head, right? From laying on just laying on their head. I've seen them on the back of their head. Trying to think of the odd places that I have seen. Oh, we had one that had one on her spinal cord. She had, I don't remember, she had something. It wasn't like scoliosis, but it was something. I can't remember what. But she literally had developed a pressure area on her spinal cord, like right above her spinal cord. And, the skin's a little bit thinner right there, and it tunneled and it opened up. So, like, literally had like a two openings and a tunnel in between from that, and it was pressure. Um, Ankles are really good, big, common ones, heels, toes. Anytime you get an admission, you want to look at every part of their body. Um, so this one is gonna probably sound a little gross, but I'm gonna tell you anyway. So we had a client, this was, I don't know, it was about 10 years ago, maybe 10 years ago, maybe a little bit longer. I don't remember. Came to the hospital, had a condom cath on. Everybody knows what a condom cath is, right? At the bottom of not all of them, but some of the condom caths have that, like that little, I don't know, like that little spongy part that you put at around the bottom just to kind of help pad it. Well, long story short, when he got admitted to the facility, the nurse did not take the condom cath off and inspect the skin underneath, was policy. We had a policy in place that anytime a client or anytime a patient came in with a condom cath, a Foley cath, not suprapubic, but Foley or a condom cath, we would change out the catheter, right? Make sure that they had a nice, clean, fresh catheter. Well, nobody did. So he was in the facility for a few days, spiked a fever. Um, they thought he had sepsis. They sent him back to the hospital. And when he went back to the hospital, that is when somebody decided to remove the condom calf. And on the base of his penis, right down where the catheter kind of was towards the scrotal sac in a stage 3 pressure area because nobody checked the condom catheter and it was on there and it wasn't, and nobody had moved it, nobody had looked at it, and it literally had ate through the skin. Um, Go ahead, Joseph.
Question, if that you're talking about a new admit,
Yeah.
so the RN was supposed to check that, right?
So so in a long-term care, LPNs will do the initial assessments and then the RNs will check off. Yes.
Usually in our long-term care facilities, the RNs do the assessment, not the LPNs.
Oh, okay.
So
Okay. So
that's
yeah.
why I'm asking who would that fall off for? Usually the LPNs will do like the basics, but the RNs come in and do the actual head to toe assessment,
Okay.
full body check.
Yep. So so in our case, it was a LPN that did the initial assessment,
Mm.
and then the RN would have to go in and sign off on her assessment.
Ooh, damn.
Yep. But then, yeah. So, and then of course, but that's why he ended up going septic, was a result of that area underneath that condom cap. Ears, especially if patients have been on oxygen for long periods of time, they may get pressure areas behind their ears. So making sure that you're checking that they're not putting those on really, really tight. There are little foam pads that you can put to help protect the ears. I'm trying to think of some of that. I want to say those were the oddest ones that I have seen. Um, yeah, I can't think of any more. If I do, I will let you know. But then again, like I said, that Braden scale does help to look and see what their risk factors are for, the development of skin pressures. All right. So what are some nursing interventions that we can do to prevent pressure areas.
Position the patient, changing them on time.
Okay. So turning and repositioning, making sure that they are clean and dry. Okay. What else?
Barrier
Make sure the
creams.
sheets are wrinkle free.
Okay. Wrinkled free sheets, barrier creams.
Use the cushions for like they use in the hospital to
Okay. The
prevent
positioning coupons,
Mhm.
coupons. Wow. The positioning cushions. Yes,
Mhm.
absolutely.
If they could get out of bed, wouldn't mobility play a factor, like ADL skills, like moving
Of
them around
course.
and having them in activities? Would that play a, as the blood circulates, making the skin a little bit stronger?
Absolutely. If we can get them out of bed, get them out of bed.
The hospital I work at, we have like these pressure pillows for the patients. You know how the beds have the sand in it?
Mm-hmm.
We have pillows like that.
Oh, okay. Okay.
You can also ensure that they're not wearing like tight fitting clothes, that they have like more relaxed clothing on.
Yep. Especially, yeah. You see some of the socks that they wear. Um, Floating the heels, right? Instead of having the heels, constantly rubbing up against the sheets, keeping them up off of the sheets. Um, what else? But like a lot of it's um prevention, good nutrition, good hydration. Um, there's a bed, cannot think of what it is called. Um, but it
Are you
can
talking
literally
about the pressure air mattresses that
the low air loss
they move in
mattresses.
positionings so the
Hmm.
body doesn't get a pressure ulcer? Like I
Yes,
forgot what you call those beds. They got them computers in front of them.
yeah,
Mm-hmm.
it's yeah, those are the low air loss mattresses. That we use those, especially if they're high risk for pressure areas.
They
Everybody,
also have sand beds.
yeah, the sand beds.
Those are interesting.
I've never worked with a sand bed.
I've had
Um,
one. I've had one, and it was not easy to like when you have to boost a patient in a sand bed, it's not easy.
well, some of the, even with the low air loss mattresses, um, you try to reposition a patient and you get that air bubble and, or you try to get them over that hump. It can be,
Hmm.
oh, I found what I was looking for. I'm gonna stop sharing my screen. I don't know. I don't even want to know how expensive these are, but these are to me like some of the coolest things. Hold on, let me share. Like I said, I don't even want to know how expensive they are. It'd be like probably be a nightmare. But look at this bed.
Oh, we have that in ICU. It turns.
Yeah, it turns
It's a complete turn.
360.
It is so cool to actually see that bed in action.
Isn't that the neatest thing? Like
It
I've
is.
never seen it. I've never seen it.
It
I
is.
I was trying to see if they had any other like pictures of it, but yeah. And
Everything
it
is still attached. IVs are still attached.
I
Um,
want to see a video.
it is
That's
so
what I want
freaking
to see.
cool.
let's see. I don't know, I put roads, let's see. Video. All right, well, I'll have to find one and see if I can find one. But I don't remember where I saw them. Um, and I was like, I really wanted to see it in action. Okay, yeah, I can't find one real quick, but yeah, to me, that would be so cool to watch those. Um, And they've been around for long, long periods of time, but you know, like I said, usually going to be pretty expensive. You're not going to find them right in a whole lot of areas. But you said you had them, Aisha, in the ICU.
Yes, they have been in ICU. I can't remember what happened to that. I actually still had, they had the patient face down, and I still had
Hmm.
to draw blood from that patient in that
Hmm.
position. No
Hmm.
matter what, whatever is need, it was cool just to see it. I thought the patient was going to fall out the bed.
Yeah. I mean, lots of advantages. I'm sure there's disadvantages to those beds as well. I'm like, how would you do an IV? Like, that's how I was, that's my, I guess I don't know. I'd have to look at it, but I remember seeing them and thinking how cool they were. Um, but yeah, anything that we can do to offset pressure, even when they're sitting up in a wheelchair, doing things like, um, gel cushions. If they're alert and oriented, reminding them to change positions frequently, right, to help prevent pressure areas. I guess my biggest thing is sometimes, you know, you get the patient up and put them up in the wheelchair in the morning and we kind of forget about them throughout the day. Even if they're up in a wheelchair, they need to be repositioned to relieve any pressure, no matter, you know, putting all the gel cushions and all the positioning devices and pads that you know, you can isn't going to, you know, prevent a pressure area from occurring if we're still not offloading the pressure. So really paying attention to that is super important. And then we're going to go into the different types of wounds. But before we do that, let's go ahead and take a break. Be back at 4:05.
Hi, man. Okay, listen.
Hello.
Say hi. Hi.
You look
Hey,
like you're about
friend.
8.
All right, so let's look at pressure area staging. All right. So this is the first picture here, is a stage one. So you can see it's just right there at the epidermis layer. So this would be that area of redness, right? So just like I was saying earlier, you sit with your legs crossed, right? And you uncross your legs, you have that red area. Um, Generally it'll go away. But with a stage one pressure area, this is what we call non-blanchable. Okay, so remember blanching, if you take your finger and you push it down on your skin, it goes a little bit lighter, and then you release it, it goes back to its normal tone. Darker skinned patients don't blanch. Okay, so this is why it is really important that when we have darker skinned individuals that we're really looking at that surrounding skin area. A stage two, you can see this is now gone a little bit deeper. It can go down into the dermal layer of the skin. This top part can be variety, it can be open. A blister also would be considered a stage two. So like heels are really good for blistering. If they have a blister, that would still be considered a stage two. Your stage three, you can see that we're almost in that subcutaneous layer of skin. We've got a lot of depth. And then in stage four, this can go, depending on how deep it is, can go down into muscle, bone. It can cause interruptions with um, nerves, all that good stuff. I was just trying to think. Other things that you may see, something called undermining and tunneling can also occur. So undermining is when this top layer of skin kind of covers part of the wounds. The wound actually will extend over into this area with the skin is still overlapping it. You may have tunneling where part of the wound now is like kind of coming off to the side as well. This one right here is what we would call an unstageable. All right. And the reason why, anybody know why this would be considered unstageable?
The top or the bottom one?
The top one.
Um, I feel like that's because it's like beyond stage four, like it's worse than that. And
Okay.
with all the skin there, it would be hard to really see like how deep it's going to go without doing like an x-ray.
Exactly. So with an unstageable pressure area, we have the full thickness, the skin and tissue loss. But we can't really determine the extent of the damage because we have this, what we call slough or scar over it. And then once we are able to get rid of the slough or the scar that's on top, then we can really look at what stage the pressure area is. This is a deep tissue injury. This will have, we see that the skin is intact, but the damage is to the underlying tissues, and that's what causes this purple brown discoloration. Um, it also could have like a blood that could like be like a blood blister. That would also be they also may have some pain and some temperature changes that occur. Again, this is from your prolonged pressure, the shearing forces, and that would lead to a DTI. And then, of course, if this were to open up, then we would be able to see what the actual damage to the tissue underneath is. So again, just cover these again. So stage one, intact skin, it's non-blanchable redness. Or, like I said, in a darker skinned individual, it would be a different, like a darker colored area. Your stage two is what we call partial thickness. We do have the exposed dermis. Okay. So, again, they could have just like a fluid filled blister that would also be considered a stage two or a partial thickness. Stage three is your full thickness. This is where we have visible adipose tissue. Um, they also can have slough and eschar in this area as well. They also, again, like said, they may have the undermining and the tunneling. And then your stage four is your full thickness. This, can go down into the muscles, the tendon, the ligaments, cartilage, bone, all of that stuff. Lots of damage all the way down. They can also have the undermining and the tunneling that occur. Um, if there's any kind of tissue slough, like I said, that would be your unstageable until we remove the eschar and the slough. Really can't determine what the true extent of damage is. So it brings us to wound healing. And so we've talked about some of the risk factors, right, associated with, how do we get pressure areas, other, other things that we have to take into consideration: obesity, malnutrition, um, cognitive impairment, like we mentioned before, are all things that we need to look at when we're doing our skin assessments and our risk assessments for pressure areas. So wound healing. It'd be great to say that these wounds all heal very easily, which in some cases it's very true. We can heal maybe the stage one or the stage two. However, then we start to get those deeper wounds, right? It makes it a little bit more difficult to heal, and let's make this bigger for you. Um, so when we look at the phases of wound healing, the inflammatory phase, lasts for 3 to 5 days after the injury occurs. We get the blood clot in there. The matrix of cell and debris form at the injury site. All right, so you can see down in here. Then we have the granulation phase, which takes days to weeks. This is where new blood vessels, your collagen, right, all start to fill in that area. We want to have a nice pink wound bed. That is our goal. And then, the maturation can last for months or years. That's the remodeling of the collagen structures, the scar contraction, all of that stuff. Once a person has had a pressure area in an area, or pressure ulcer in an area, they are going to be at an increased risk for developing pressure areas again. So once it heals, it's still a matter. We still have to protect that skin so that they don't develop another area. All right. So here we go. Miss Bettis is an 89-year-old resident at a long-term care facility. Mr. Bettis, sorry. He is no longer able to walk and spends most of his time in bed. He is underweight and has a poor appetite. What stage is his heel injury? What stage does that look like?
I would
One.
say 2 or 3 for that one.
This one?
Yeah.
No
One.
broken skin and it's red.
Stage one.
So this is a
One.
stage one. How do we check to see if he is, how do we check to see if he has blood circulation to the area?
Press on it.
So we can press on it, right? And see if it blanches. How do we help him recover from his injury and prevent further damage?
Prop it up like off of a pillow or heel protectors.
Okay, prop it up,
Skin
heel
prep.
protectors,
Skin prep to the heels.
skin prep to the heels, right? If
Make
he's
sure
no
it's
longer, go ahead.
make sure it stays moisturized.
Okay, make sure it stays moisturized.
I was gonna
Um,
say nutrition.
yeah, he's underweight and has a poor appetite, so we definitely have to get him to increase his intake, right? So what foods are important for wound healing?
High protein.
Okay, high protein, right? So we need to figure out, and so if he doesn't want to eat a whole lot of foods, what are some other things that we could give him?
Protein
Protein
shakes.
shakes.
Protein shakes, right? Supplements. All right, good job. Oh, all right. Miss Ella is 90 years old. She has dementia. She's been wearing an ankle brace for 3 months to prevent heel ulcers. This pressure injury developed on her ankle. What stage would this one be?
Stage 3.
Stage 3. Very good. What could have caused her skin breakdown?
Wearing the ankle brace too much.
Right? Wearing it too much, putting it on, it's too tight, right? That's causing pressure on that area. Or yeah, wearing it all the time, lots of, maybe put it on too tight. Good job. All right. Mrs. Smith is 64 years old. She had a spinal cord injury 7 years ago that left her paralyzed from the waist down. She developed a pressure injury on her hip that has not healed. What stage is Mrs. Smith's pressure injury?
Stage 4.
So yes, this one would be a stage 4. And so I'm trying, of course, I can't see from a picture. I'm don't I don't know if that second Q-tip is showing undermining or tunneling, but it could be either one. All right. So to determine, you will take the sterile Q-tips, all right, and you'll just kind of look and see if any of this. See, to me, this does look like it's kind of overlapping, but again, from the picture, it's hard to tell. It's a little bit easier in real life. But you'll take that Q-tip, and you will literally put it in there, see how far the Q-tip goes, and then you'll measure it to see how far the undermining or how far or how long the tunneling is. Um, what are some nursing interventions that we could do to prevent further injury to this area?
Turning
Um,
every 2 hours.
Yep. Turning, repositioning every 2 hours. What else?
getting a proper wound care order put in place.
Okay. So we can get a wound doc to come and look at it, make sure that we have the right treatment in place. What else?
Um, Making sure that she's taking in the proper nutrition to help for healing.
Yep, absolutely. So nutrition, hydration, right? Even range of motion, right? Help get that blood flow to the area. Um, okay. All right, here's another one. So Miss Stevens is 71 years old. She is staying at a long-term um, acute rehab facility. She fell at home and broke her right shoulder and two right ribs. She prefers to lie on her left side because she has so much pain when she is repositioned. Today, the PN finds a partial thickness open area on her left hip. So, what stage is this?
2.
It's a stage 2. And how would we reposition Miss Stevens to avoid further damage?
Lying flat on her back or even onto her right side. And if she does need to go onto her left side, um, placing like pillows or something on there so that way it's not so much pressure like on like right on the bed.
Right? So we can put like pillows around it, right? So that it's not laying directly on the bed. Making sure too when we're turning and repositioning, like I was saying earlier, turn sheets are effective as well to help you turn your patients. Even if we're sliding them up in bed, right? We want to lift and pull rather than just drag them across the sheets. That will also help to, prevent some of the shearing that occurs when we're repositioning our clients.
Can I say something?
You can.
So, I know that a lot of the times, a lot of these residents have air mattresses,
Hmm.
and technically, we're not even supposed to be using anything but a fitted sheet on an air mattress. So
Actually,
I
no
think,
fitted sheets. You're not supposed to use fitted sheets.
oh, so just nothing on the bed. Dang.
Yeah.
So that does
Um,
contribute to a lot of these breakdowns then.
so you can use a turn sheet on them. So, your turn sheets and your incontinent pads can still be placed under your residence, but you shouldn't be using the fitted sheets.
See, here in Pennsylvania, they have said that if it's an air mattress, unless it's one of the disposable incontinent pads, because the cloth ones are so thick, we're not supposed to use incontinent pads on an air mattress.
Right, because it doesn't allow for the flow. But we use the chuck pads. We don't use like the thick cotton, like the thick material ones that a lot of places use. We just
Mm.
use the blue
A lot
chucks
of places here are cheap and don't want to spend the money on the disposable ones, so they get the thick cloth ones.
and thick. So instead of using that, you can use a sheet, use like a not the fitted sheets, like a top
Flat
sheet.
sheet.
Yeah. Then why couldn't I think of the word flat sheet? Thank you, Sydney. I
You're
was like,
welcome.
what is it called? You can use a flat sheet that's a little bit thinner than those thick incontinent pads. Will allow for a little bit of the flow. But yeah, technically you're not supposed to use the fitted sheets on those air mattresses. Um, some of the air mattresses I've noted, and I haven't seen one in a long time. But some of the air mattresses actually came with protective like covers on them. Kind not like it's like a sheet, but not like a sheet. It's removable and washable, but I haven't seen one of those in a long time either. So, all right. So let's now talk about elimination. Go from one to the next. So chapter 18 is in your basic geriatric book, and then in your nursing, your concepts for nursing practice, it'll be chapter 17. So we talk about elimination. One thing that I want to stress to you is that incontinence is not a normal part of aging. Just because you get older does not does not mean that you become incontinent. Um, and so, I know a lot of people tend to think that, um, just because you get older, you become incontinent. There is obviously a huge part of the older population that have problems with elimination. Um, and so, it could be incontinence, it could be diarrhea, it could be constipation, be a variety of different things that occur. So elimination is just the excretion of waste, right? Your urine and your feces. Um, Impaired elimination can cause serious health complications, right? Including fluid retention, UTIs, kidney damage, bowel impactions. It could also lead to the development of pressure areas or even what we call maceration, which isn't necessarily a pressure, but I guess for lack of a better term, it's like diaper rash, right? That we would see like, just from the urine staying on the skin and causing damage. Um, so your exemplars of your impaired elimination or constipation, diarrhea, urinary retention, and urinary incontinence. Um, so incontinence is the most common reasons that older adults are institutionalized, which is kind of really sad if you ask me. But bowel elimination, so we'll start there. Most adults experience bowel elimination every 1 to 2 days, right? Not everybody has a bowel movement every day. It could be every other day, even in some cases every third day. It really just depends on the person. The urge to defecate most commonly occurs 30 to 45 minutes after a meal when the gastrocolic and defecation reflexes stimulate peristalsis. If they haven't had a bowel movement in more than 3 days, that does require intervention. Um, so constipation is hard, dry stools that are difficult to pass. Constipation is not a disease. It's just a symptom of another issue. In it, some of the complications of constipation, painful defecation, right? That can lead to avoiding bowel movements, right? So if you know it's going to hurt when you go to have a bowel movement, right? You may stop yourself from having to go. Um, Pressure from straining, so trying to push the hard, dry stools out can lead to hemorrhoids. It also can lead to other GI complications, cardiovascular complications as well. Um, and then fecal impaction, which is a blockage of stool in the rectum, could lead to it can extend to the sigmoid colon, potentially leading to bowel perforation. So some of the things that increase the risk or the chance for constipation to occur, especially in our elderly population, decreased abdominal muscle tone, inactivity, immobility. And I'm going to say this, think about how you have your bowel movements, right? You're sitting up on a toilet, right? To have your bowel movements, which gravity can assist. Imagine having to lay in a bed and lay flat and have a bowel movement, right? It's can be very difficult for some. If they're not drinking enough fluids, that can lead to constipation and those hard, dry stools. Not getting enough bulk in their diet. And of course, you can throw in diseases and medications, and the rest of their environment can all lead to constipation. I don't know why because I made it bigger. Um, Fecal impaction, again, that's that hard mass that's trapped in the rectum, can't get it out. Um, and that is usually the result of unrelieved constipation. So digital exam of the rectum, you'll feel the hard mass of stool. Imagine how uncomfortable that could be if you've had this huge packed, hard packed stool just sitting there and you're unable to get it out. It can lead, can of course grow and get larger. The impaction can grow and get larger, which eventually could potentially lead to bowel perforation, which would be significant in our older population. So, other risk factors for constipation, neurologic disorders, strokes, Parkinson's disease, MS, tube feedings. This is a big one right here, tube feedings. How tube feeders get dehydrated is beyond me, but it still happens. So if you have a tube feeder that is not on a kangaroo pump, getting that scheduled flush already hooked up, please make sure that you're going and you are flushing those tubes and giving them the water that they need. GI obstructions, inadequate fluids, cognitive impairment, right? Talked about those issues. What? Oh. All right. So assessing or nursing interventions for constipation. So we talked about it, right? So, diet's going to be one. So making sure they're getting lots of fiber, lots of fluids, or not lots, but, as much as they can handle, of course, if they aren't already on fluid restriction, getting them up and moving if possible. All right. So gravity does help with peristalsis and bowel elimination. So if we can get them up and moving, that will help. Scheduled toileting at times when the person's defecation urge is strongest, right? So we already talked about how the strong is, or that to get the urge after eating. So putting them on the toilet after meals may be helpful. Consider lack of privacy, embarrassment, fear of pain. All of those can be something too. Not everybody is used to, going and sitting on the toilet and have somebody staring at them while they're using the toilet, right? So making sure that we're providing some privacy. You can do stool softeners or bulk forming laxatives as well. We can do stimulant laxatives, enemas if the other's not effective. And then, things, there's usually a protocol in most of your facilities that if a patient hasn't had a bowel movement in 3 days, then, there's a sequence of events that will take place. Usually a lot of times it may start with some like milk and mag, or something along those lines. And then if they don't go, right, there's a process that you will follow. Laxatives. So some of your older adults also may overuse laxatives. And I'll explain this. As you get older, right, you lose a lot of control over a lot of things in our life, in a person's lives. And so bowels are usually one thing that they, get hyper focused on. Um, and so making sure that they're having bowel movements, they may start to use the laxatives, to try to ensure that they're always going. The overuse of laxatives is not, it's not good for them. It's once they become dependent on the laxatives, so then they won't be able to go on their own without it. So here's some examples. Your stimulant laxatives like Senna, they can cause cramping or vomiting. Give only occasionally and use caution, which is interesting because I've seen patients, they take Senna every single day. Castor oil, on the other hand, I'm not giving castor oil, but that is another option. Your bulk forming laxatives like Metamucil, you can use these for long-term use. They may cause some gas or make stools difficult to pass if not given with adequate fluids. Has anybody ever taken Metamucil before? Got a funny story about Metamucil. So when I was pregnant with my youngest, got a little constipated. Okay. So I called the doctor and they're like, oh, you can use Metamucil. So I was like, okay. I'd never used it before, but I was like, I'm willing to try anything. So I'm in the kitchen, I had my glass of water, I mixed my Metamucil, and the doorbell rings. And so I go and answer the door. I don't remember who was at the door at the time, whatever, but I was probably there for about 10 or 15 minutes. And they go back to the kitchen. The Metamucil is now Jello consistency. It, if you don't drink it right away, it almost solidifies. It is crazy. Um, so, when we look at that, And I was like, I didn't, I just dumped it and, started the process over, but you have to make sure that you're giving them enough fluids with those bulk forming laxatives because if you're not giving them enough fluids, it's going to make the stool harder to pass. Then, of course, you have your stool softeners like your DocuSit. They make the stools easier to pass, but they're not effective for chronic constipation. Um, I mean, you can give this every day. It's not that big a deal. Then we have our diarrhea. Um, and so on the opposite side of that of constipation, is the frequent passage of loose, unformed or liquid unformed stool, which can also lead to skin irritation and breakdown, right? Especially if they're incontinent and they're wearing incontinent briefs, right? That diarrhea can sit against their skin and cause irritation and breakdown. Again, diarrhea is a symptom. Um, can have many causes, right? Lots of different things can cause diarrhea. The biggest concerns with diarrhea is fluid and electrolyte loss. Um, Depending on how severe the diarrhea is, they can lose in excessive amounts of fluids. So, of course, we want to report and monitor any patients with diarrhea so that they don't become dehydrated. Replace fluids with water, electrolytes, drinks, or juice, and then give them bulk forming foods, bananas, mashed potatoes, that kind of thing to help bulk up the food or bulk up the stool. Of course, we also want to determine what the underlying cause of the diarrhea is, if possible. Um, if it's an infectious process like C. diff or something, obviously we want to know what the cause is. But like your tube feeders, they can get dehydrated really easy, but a lot of times they have diarrhea as they are starting to what's the word? Get used to the tube feeding. Some will stay with loose stools as long as they're on the tube feeding. Other may start to have a little bit more of a bolt to their stool. All right. And then we have our urinary incontinence. So urinary incontinence is the involuntary loss of urine. And again, it is not a normal part of aging, but it is a major problem. So some of the risk factors, advanced age is a risk factor. Like I said, it's not a normal part, but it is aging is a risk factor. Caffeine intake, immobility or functional limitations, right? How easy is it for them to get up to go to the restroom? What medications are they taking, especially your diuretics? Obesity, smoking, fecal impactions or fecal incontinence can also lead to urinary incontinence, malnutrition, depression. For our gentlemen, if they have an enlarged prostate, that all or being treated for prostate cancer would also increase their risk for urinary incontinence, low fluid intake, diabetes, stroke, Parkinson's. I'm trying to think. In women, estrogen depletion could also be a risk factor for incontinence, or even being in a long-term care facility can also lead to incontinence as well. Um, why do you think that is? Why do you think if why do you think being institutionalized would increase their risk for incontinence?
Um, I mean, sometimes it's because they'll go into like a depression and they don't really want to move and get up and do anything. And sometimes just like lack of staff and not being able to make timely rounds and getting everybody toileted on time.
Very good, because if I'm continent and I'm able to use the toilet, but I need assistance in getting there and I don't get the assistance, right? That could lead to that incontinence. Very good. On the other hand of this, we have urinary retention, which is an abnormal accumulation of urine in the bladder, and then the bladder can't empty completely. And there's a variety of causes for this as well, right? Um, if there's decreased muscle tone in the bladder, decreased fluid intake, um, prostate gland enlargement in our gentlemen, neurologic damage, medications, anxiety, all can lead to urinary retention. They'll feel full, distended. They'll have discomfort or tenderness in the bladder. They also may have some restlessness, anxiety, as a result. So treatment for urinary retention is going to depend on what the cause of urinary retention is. There are some medications that can cause urinary retention, anesthesia. If it is severe or caused by obstruction, then of course we can do catheterization. Generally don't like to do the indwelling Foley catheters, right, for long periods of time. But we can do like the in-out paths. There may be some surgeries, to go in there and open the obstruction. Maybe it's something simple like a stone or something like that, or it could be something that maybe is a little bit more serious where they need to go open a constricted urethra or something along those lines. But this is what I was talking about earlier. The patients that have incontinence, it doesn't matter male or female. Um, when they go in those briefs and we leave them in those briefs for periods of time, it can cause skin breakdown. And that skin breakdown can be very painful. Um, and then we have our types of urinary incontinence. So stress incontinence is leakage of urine during conditions that increase intra-abdominal pressure. So jumping, lifting, coughing, sneezing, um, I said jumping, that could lead to um, the leakage of urine. This could be just because of weakened muscles due to aging or even from childbirth. Your urge incontinence is caused by involuntary contraction of the detrusor muscle of the bladder. So they get this strong, sudden urge that they have to go to the bathroom. They usually, they'll get that strong, sudden urge and generally don't make it to the bathroom in time. And that's what leads to the incontinence. Your reflex incontinence is the involuntary loss at fairly predictable interval after a certain bladder volume is reached, right? And so, whenever the bladder reaches that certain volume, it's going to go ahead and relax and cause the incontinence. Your overflow incontinence is the leakage of small amounts of urine from an overly full bladder. So, got your bladder's full, you haven't gone, and you'll have some overflow incontinence. Gentlemen can have overflow incontinence as well, and if they have the enlarged prostate. And then your functional incontinence, this is seen in those have normal bladder and urethral function. But generally what it happens, it's, they have that physical or cognitive disability, and that's what leads into that functional incontinence. So what can we do? So I think it was Jackie, you were mentioning staff is a big part of this, especially in long-term care and hospitals, right? Making sure that we're toileting them, as needed. Always this, when we do that intake, admission assessment, we are going to assess their elimination patterns, right? What's their normal scheduling pattern at home? Um, Kegel exercises, are always a good idea. Doesn't matter how old you are, doesn't matter if you're male or a female, but your Kegel exercises are effective. Uh, environment, making sure there's grab bars, toilet risers, for that person in order to go to the bathroom. Um, Things like making clothing easier too, right? You don't want to have like tight pants and stuff or belts and things that's going to take you a while to get to the bathroom to undo those. Um, Scrub pants are a danger as well, just to let you know. I had to go one day. I drove all the way home from the hospital and I pulled into the driveway and it was like as soon as I got out of the car, it hit me. So I like ran into the house. And when I finally got to the bathroom, there was a knot in my scrub pants. It was the first time in my life I ever just wanted to take my scrub pants and just cut them off. I'm like trying to get this knot out. I was like, oh, it was horrible. And so be careful with scrub pants too. All right, last one. Pam is a 71-year-old woman who has urinary incontinence when she sneezes or laughs. Her husband Arnold is an 80-year-old man who has incontinent episodes when he moves furniture or boxes around the house. What kind of incontinence is that?
Stress.
And that's the stress incontinence.
Stress.
Yep. So what can we do for them?
Maybe have him use the restroom before he starts moving like furniture or anything like that.
Yep. Yep. So yeah, so maybe having them empty their bladder, right? Recognizing those symptoms, getting before they get ready to do those activities. All right, guys. It's anybody have any last questions? It is time.
Slide 44. Was
Uh-huh.
that about wounds? Like
No,
all I
that's
saw was a
nasty. That's the moisture associated.
okay.
That is from basically from sitting in a wet brief.
Okay.
Yeah,
Thank you.
you're welcome. All right, you guys have an awesome week, and I will see you next week.
You as well.
You
I'm
Thank
too.
not
Thank
sure if
you.
you don't
you.
feel well, but I hope you feel better.
Thank you.
You're
Oh,
welcome.
feel better.
Thanks.